Hey guys, this is Mike Self.
And Chris Coyne.
We're here to talk to you about postpartum complications because having a baby isn't hard enough by itself. Going to take you through a basic outline of our presentation here. So first we're going to talk about postpartum hemorrhage. We're going to talk about the definition, what that means, any risk factors, balloons, a little aside on balloons, and then we're going to talk about how you manage postpartum hemorrhage by etiology in the emergency department. Probably the most important part of this. You ready?
Let's do this.
Should we get another beer first?
Got it.
All right, so the definition of postpartum hemorrhage. So there's two types of postpartum hemorrhage, early and delayed. Early is less than or equal to 24 hours of delivery. And the American College of Gynecologists wants you to think that over 1 liter of total blood loss is postpartum hemorrhage. And you can see this nice diagram on this side, which is just awesome.
It's the mannequin laying in the lower right-hand corner, which is our greater than 1,000. So if you see that patient coming in, that's the only one that actually matters.
And you can see the ED version of this is much better. I think a 10% crit drop, the need for transfusion, they got a hemoglobin less than 7 or they're just hemorrhaging out of their vagina. And vital sign changes, that's what we care about. Delayed postpartum hemorrhage is over 24 hours from delivery. It's the same definition. Obviously, it's going to be hard to guesstimate their blood loss from there. All right, so let's talk about the risk factors for postpartum hemorrhage. So retained parts is a big one. There are a couple big studies that were done, case control study and a retrospective cohort study. The first case control study, retained parts was the biggest risk factor. The prolonged second phase of labor, abnormal placentation, lacerations, instrumentation, yada, yada, yada. And some of these play into each other. Like LGA babies, are more likely to have instrumentation or lacerations at delivery. And
Absolutely.
Then preeclampsia predisposes you to things like thrombocytopenia and coagulopathies. So,
and you can imagine, like the picture here with the instrumentation, how that could definitely cause some trauma. I mean, that's one of the things you definitely want to check, even in your non-OB patients or post-OB. You definitely want to make sure you're checking for lacerations because that's one of the things that we usually don't think about.
Some extracurricular instrumentation.
Yeah, I wasn't even going there, Mike. Not with this talk. That's a different talk.
All right. So on to general principles of postpartum hemorrhage. Obviously, like anything in emergency medicine, you're going to want to talk about your ABCs. So you're going to want to try to estimate the volume of bleeding and give them back their volume and blood if indicated. At the same time, you're going to want to try to determine the etiology. This means a pelvic exam. Can't get away from it this time. And then basically all patients with postpartum hemorrhage are going to get uterotonics. Do you agree with that?
Absolutely.
The things you remember about pregnant patients is that they have an increased total blood volume, and that's going to delay your typical signs and symptoms of hemorrhagic shock. So just remember, in a pregnant patient, vital sign changes are bad. You can have a 30%, like almost a third, loss in your total blood volume before you can start having changes in your vital signs.
Even tachycardia.
Yeah, even tachycardia can be a bad sign. The other thing that's been well studied in postpartum hemorrhage is actually TXA. You can see a little aside about that on the right side of the screen. The Woman trial was a large prospective randomized double-blind controlled trial, and it found that TXA reduces the death due to bleeding, but it did not if you gave high dose TXA. So that's 1 gram IV.
Big dose. Yeah.
Big dose. That's repeat once if they're still bleeding within 24 hours. So that's something you can definitely consider. It would be, I think, you think it's standard of care to give a big dose TXA?
If they're bleeding like that mannequin in the right lower quadrant of that picture, then absolutely. I think
awesome.
there's very little downside, especially in this case.
So the other thing to think about is when you're having someone who has vital sign changes and they have hemorrhage, just make sure that the amount of bleeding, make sure it is that mannequin in that right lower quadrant, and make sure, and if the amount of bleeding doesn't really fitting the clinical picture. Don't ignore things like sepsis,
Absolutely.
epidural complications, other causes of hypotension or tachycardia in your peripartum patients.
Which we will get to some of those potential causes at the end of this talk.
We sure will. All right, so let's go into a quick aside about balloons. So these are a variety, a sundry, if you will, of balloon. You like that?
That's
you
what
like
I call
that?
a sundry.
Of
Potpourri of balloons.
And the one on the far right is my favorite because it's jerry rigged with I think that's just like a straight cath and a condom that they tie some suture around. So if you're in a third world country with limited resources, you can use that. So these guys, you can insert.
So El Centro.
Yeah, basically El Centro, or Hillcrest some days.
Yep. Depends on the day.
So you can insert manually, or you can use instrumentation. There's not really a defined way to do this. Some people advocate ultrasound guidance to make sure your balloon's in the right spot. And then these patients usually require analgesia and antibiotics.
Oh, absolutely. But I mean, you got to remember, like they just gave birth, so it's not going to be that difficult to place these. But definitely be careful. You don't want to cause any more trauma.
Yeah, and most of them do actually. They're in the studies looking at the efficacy of these. Most of them did get prophylactic antibiotics, so that's something to consider.
Yeah.
And at this point, you're probably already going to be on the phone with your OB colleague, so make sure you talk to them about that if they can't come and see your patient as urgently as you'd like them to.
Yeah, and this is much more relevant for people that are practicing in areas where they don't have easy access. So for us, at UCSD, it's not going to be an issue, but you really need to know how to do this and know about this once you go out into the real world.
God, the real world sounds scary.
Yeah, it's fun.
All right, so let's go into talking about postpartum hemorrhage, how you manage it, and we're going to go managing by the etiology. So there's 4 T's of postpartum hemorrhage, and that's...
And what are those T's?
Oh, so those T's, fancy you should ask, Chris. So those T's are tone, trauma, tissue, and thrombin. Thrombin meaning kind of a basket just talking about hypercoagulability. So let's talk about tone first, because this is the vast majority of patients you see with postpartum hemorrhage.
Uterine atony.
Uterine atony.
Yes.
Atony?
That's atony? I don't know. This is the only thing I remember from my OB rotation.
So this is when the uterus don't squeeze good. To put it simply, this is 80% of your patients with postpartum hemorrhage. This is going to be the etiology. It gets a little complicated because retained products of conception can cause uterine atony, so can endometritis, but this is going to be mostly what you're worried about. So the first thing you're going to do is aggressively punch the uterus, as illustrated here. You're going to do something called bimanual uterine massage.
Is that a Netter drawing?
It probably is. I mean, that is just vicious. And I looked for other less vicious pictures, but I mean, I guess this is what you have to do.
That's the massage.
So this is going to try to increase the tone of the uterus. It's a step above what you do with the fundal massage when you're trying to, deliver the placenta. You're always going to start uterotonics, and the table below kind of goes over which uterotonics. Oxytocin gets a star because that's first line, and most of your patients are going to get oxytocin. It's actually standard of care to be infusing oxytocin during delivery to prevent uterine atony. And that you can see the doses there. The other thing to consider is a balloon catheter. If everything else has failed, you can't get this uterus contracted. Maybe something else. Maybe they got some tissue stuck in there still. Try a balloon catheter if everything else is failing and you don't have OB down at your bedside. All right, that's tone. Let's move on. We're going to talk about trauma. So there's a few entities here in trauma. So one thing you got to think about is lacerations. We talked about how instrumentation is a common cause of, or one of the risk factors for postpartum hemorrhage. So
Absolutely.
If you have lacerations, you're going to want to repair them. You can do figure of 8s. You can do 2 or 3 absorbables. Repair up any lacerations you see. If you see any hematomas, you want to IND those if they're over 3 centimeters. And
to be honest, like if you see a laceration, don't worry about the suture that you have. Just find a suture and throw it in there. You gotta. These can be arterial bleeds sometimes, so just get that figure of 8 stitch in there.
Stop the bleeding.
Stop the bleeding.
Uterine version is a big one. So this is, basically when you're trying to, usually it's from overzealous delivery of the placenta, say by an impatient ER provider who just wants to, get this
get their
out of
births
there,
done and signed off, and then get out of there.
and get the hell out of there. So it's a clinical diagnosis. You're looking for vaginal bleeding. You may see the placenta coming out of the fornix. It may be occult and really not going much through the cervix, but this can cause a ton of vaginal bleeding. You're kind of between a rock and a hard place because uterotonics like oxytocin can make this impossible to replace.
Yep.
When you want to try manual replacement, as you can see in the illustration here, you're just mean to the uterus today. Balloon catheter is something else you can try. If that fails, you may have to use tocolytics. You're definitely going to need analgesia, and this is something that OB may need to take to the OR to do under anesthesia.
Yeah, and this is a situation that's tough because whenever you're thinking postpartum hemorrhage, you're always thinking give uterotonic, but this is a case where you actually want to eliminate those contractions so you can then relax the uterus and push it back in. So hopefully you never encounter this, but just know that it might be needed in this case.
Just go easy on the placenta. Let it take time,
Slow
is smooth, and smooth is fast. All right, moving on. So uterine rupture. This is a big issue. So rare, but potentially life-threatening for both of your patients, the mother and the fetus. So change your underpants and call your surgeon. The ways to look at uterine rupture. So trial of labor after cesarean section or vaginal birth after cesarean section is usually it's the biggest risk factor.
Absolutely.
Macrosomia or augmented labor, which almost all labors are augmented these days, are also risk factors. Things you're going to look for are persistent abdominal pain with severe vaginal bleeding. And if you have a loss of station, so baby's like making its way down. Oh, where'd baby go? In the peritoneal cavity. Uh-oh. And then a palpable uterine defect is another.
Yeah, and you're talking about during delivery too.
Correct.
So in this case, if we're seeing them after, obviously we all use ultrasound quite frequently. So definitely get your ultrasound out. Look for, a lot of free fluid in the abdomen. You might have some postpartum, especially in the pelvis. But if you're looking at Morrison's pouch, the splenorenal area, you shouldn't have a significant amount of fluid, if any, there. So that's one other way to diagnose a suspected uterine rupture.
That's a really great point, and I think looking at ultrasound for uterine inversion too, if you have a uterus that's not inverted past the fornix, it's kind of in the cervix, you can use that to kind of use ultrasound, transabdominal ultrasound to see where your uterus
Absolutely.
is. All right, so let's move on. Next up is tissue. So what we're talking about with tissue are retained placenta or membranes, retained products of conception, basically.
Yeah.
Some risk factors for that: you can have invasive placentation or abnormal placentation. Obviously a problem. And if you have someone with delayed hemorrhage, this is probably the biggest cause of delayed hemorrhage. People don't get all the placental membrane or placenta out.
Yeah, I think that's actually like going back to the uterine inversion. That's another risk factor for that as well.
Oh, of course.
Right, because
right.
you're trying to pull that placenta out. If it's actually implanted deeper into the uterine muscle, then you're not going to be able to easily deliver that.
Yeah, so you have two problems there.
Yeah,
that sucks.
That sucks. I don't want to be that. I don't want to be that doctor.
I really don't want to be that doctor. If someone comes in with fevers and sepsis and vaginal bleeding and they just delivered, think about endometritis or infection due to these retained placental tissues.
Absolutely.
Consider ultrasound. So this is the image here is an ultrasound image, and what you can see is increased blood flow within a certain part of the uterus, and that's suggestive of retained placental tissue. Something you probably want to get a formal ultrasound on, just to make, because honestly, how often do we do these?
Yep. The anatomy is going to be abnormal. They just delivered. I would definitely get a formal ultrasound if possible. If it's hemorrhaging, then it might not be that easy to do that. But maybe after putting a balloon in there, then going to get the ultrasound.
Yep. If you're in El Centro or somewhere in the middle of nowhere, don't have OB on call, you can consider balloon tamponade to temporize these patients, but ultimately they're going to need an obstetrician to come in. They may need to do a DNC or some other surgical procedure to stop the hemorrhage.
And in rare cases, they might actually have to do a hysterectomy.
Yeah, and that's kind of the end game for a lot of these causes, or a lot of this postpartum hemorrhages. Patients end up getting hysterectomies. They end up getting uterine artery embolizations by interventional radiology, and that's kind of a big deal. That's the first baby. That can be a really negative consideration for patients. So your management can kind of help try to prevent that. All right, let's move on to the next and the last etiology of postpartum hemorrhage. So this is thrombin. I throw in thrombocytopenia in this one too. So we're talking about coagulopathies here. So GIC, especially in patients with intrauterine fetal demise, you want to think about GIC. Any other kind of known coagulopathy. In all your postpartum hemorrhage patients, you want to send off labs for GIC. Send off a thrombin, a PTINR, PTT, CBC, as well as your normal labs. Replete factors as needed, and remember that these patients are basically like a trauma hemorrhage out of their vagina, and so you're going to want to treat them like that. Treat them like they're bleeding to death, because they are.
Yep, absolutely. So the massive transfusion protocol. Do not feel hesitant about initiating that 1-to-1-to-1.
Yep, get that those platelets and that FFP on board.
Yep.
So let's go back over the important parts about postpartum hemorrhage, and this is really the bulk and the biggest topic of this presentation. So, if you have vaginal bleeding and vital sign changes in a patient that's recently delivered a baby, that's the big consideration here. And then take a stepwise approach. So start with volume resuscitation, your ABCs. Go to bimanual uterine massage if you're considering atony, which is the most common cause.
Most common, exactly. Most common cause. You got to go with that first.
Low-hanging fruit, man. Low-hanging fruit. Move to oxytocin and TXA. Remember, there's good evidence to support you using high-dose TXA and oxytocin.
1 gram. 1 gram.
1 gram. Easy. Just remember one.
And potential repeat. If not, if it's still bleeding.
2 Hey, give them 2. Why not?
Yeah. Hey, why not?
Consider a mechanical tamponade, such as a balloon or vaginal packing.
I bet you could probably use even some of the GI balloons. Let's say you can't find the typical ones. Like you could probably put in. We have the Blakemore UCSD, but some of the other balloons would be just as
So there actually is evidence for that. Yeah. That paper that the pictures of all the sundry of balloons came from actually go over a bunch of evidence for putting in those kind of balloons to stop this kind of bleeding.
Yeah, absolutely.
And then remember that if you can't stop this, OB, the operating room, and interventional radiology are your friends.
Great.
And then remember the 4 T's of postpartum hemorrhage when you're figuring out the etiology. Woo!
Tone, trauma, tissue, thrombin.
Tone, trauma, tissue, thrombin. All right,
well done,
that's postpartum hemorrhage. Let's move on to mastitis.
Change gears.
Now we're talking about breasts. So mastitis, talking about how this comes about. So you have a new mother, they're trying to figure out how to breastfeed. How much fun is that?
That's gonna be
in
tough.
Your personal experience.
It
was tough.
Yeah.
I mean, it's not fun.
We both have wives that have fairly young kids.
Yeah.
Mastitis, not a good thing.
Not a good thing. It's challenging.
Yep.
So mastitis, what happens? You get a blocked duct. There's a reason this usually happens within the first 6 weeks of pregnancy, because you're having some issues with breastfeeding, figuring this whole thing out. You don't get the milk out that you might need to. You get a blocked duct, it gets engorged, it gets inflamed, and guess what? Breast milk is a wonderful medium for bacterial growth. And so it gets infected and ultimately may form an abscess. This happens usually weeks to months of breastfeeding. And you can see a little bit of a refresher on breast anatomy there. So how are you going to diagnose this? This is clinical. This is a clinical diagnosis.
Yep.
You should probably have a breastfeeding mother.
That would be,
to start. Increasing pain, fevers, chills, some flu-like symptoms, and you want to have some signs of an infection. Think about cellulitis. Do we see cellulitis at Hillcrest?
No.
Really?
Never.
Oh.
Yeah. Yes, cellulitis. Just to mention here, you got to keep in the back of your mind, and we always talk about this, but we don't always think about it, is inflammatory breast cancer too. They can get it. It actually happens quite commonly postpartum. So just think about it as well. Just want to throw that in there.
Don't take your new moms to La Jolla.
Yeah, because that would mean they definitely have cancer.
Definitely have cancer. So, if much like your other patients with cellulitis, if they have systemic symptoms, if they're tachycardic, if they're febrile, they're nauseous, they're vomiting, you probably want to get labs just to make sure. And then if you feel an area fluctuous in the breast, you should probably get an ultrasound.
Yeah, that's a good idea.
Do a bedside ultrasound. Make sure they don't have an abscess.
Yeah.
Right? Because that means something else.
It can be somewhat difficult if they're very engorged breasts to see like a focal fluid collection that's consistent with an abscess. So one other way is to potentially stick a needle in it.
Would you ultrasound all your patients with mastitis? With you're considering mastitis in?
No, I still think it's a clinical exam. I think that if you feel an area of fluctuance, then go ahead and do it. Although it probably wouldn't be wrong to just put an ultrasound on there and make sure that everything looks okay.
I guess the alternative would be to try them on antibiotics, see if they get better, and if they don't, then you kind of think they have an abscess.
As long as they have the ability to follow up easily, then that's fine.
All right, so we kind of got into treatment here a little bit. So if you don't suspect an abscess and you just have mastitis, your treatment's really, if you can start with just hot compresses and NSAIDs. And if it's been less than 24 hours, some literature actually suggests you can just do this and see if they get better. Again, I wouldn't do that in patients that don't have good follow-up.
Yeah.
You want to keep them, the big thing to stress is they keep emptying their breasts and they keep on breastfeeding.
Yeah, keep breastfeeding.
Keep breastfeeding. Keep breastfeeding. Keep emptying your breasts. Frequent emptying is really important in the way that they're going to kind of get through this mastitis issue. And then antibiotics, you want to cover staph, strep, and E. coli.
Yep.
So dicloxacillin is the first line. You can also use Keflex or Clinda. Don't use Bactrim for breastfeeding, I believe, or at least like little kids or little babies. Is that right? I think it's right.
It's not recommended.
Not recommended. And then you want to give everyone a 10-day course. So breast abscesses. You want to do an ultrasound, and you do an ultrasound guided needle drainage.
Yep.
Chris, would you ever cut into a breast abscess with the scalpel?
Absolutely not.
Absolutely not.
No.
Are you a plastic surgeon?
Happen. No. Are you?
No, absolutely not.
Okay.
Nor I'm not training to be one.
All right.
So you never want to do a scalpel IND of a breast abscess. Try a needle drainage. If it's loculated or looks nasty or complicated, you can get them to a plastic surgeon who can cut into their breast without causing
significant trauma and
lifelong ugly scars.
Yeah, that would not be good.
No, that's you getting sued. And then these patients probably need a surgery follow-up just to make sure that they are improving and don't need further incision and drainage. And then all these patients need 10 days of antibiotics, regardless of whether or not their abscess is complicated.
Mm-hmm.
All right, so summary for mastitis, you're looking at breast pain, swelling, and systemic symptoms. Happens within the first 6 weeks. You got your...
Typically. It can happen a little bit later than that, too.
Okay.
But yeah, that's the most common. Early in pregnancy.
You want to use NSAIDs, warm compresses, antibiotics, frequent breastfeeding and emptying of the breast, and then if they have an abscess, do a needle drainage and refer them to surgery.
You got it.
Solid.
Well done.
Let's move on.
Let's.
RH alloimmunization. So this is what we're going to talk about. We're going to talk about the pathophys with risk factors. We're going to talk about the management, prevention, program. We're not actually going to talk about high drops because that's something that's kind of outside of the scope of this.
But that's a complication.
That is a complication.
There you go.
Maybe we can talk about that now.
That's our topic, or that's our little talk about high drops. That
covered.
Mentioning done.
Prevented by giving Rogam appropriately.
Please do.
And then when to talk to OB. All right, so the pathophysiology.
Nice rhesus monkey there.
Look at that.
That's a scary ass monkey.
I know, man. The thing will eat you. Look at those teeth.
That's straight outbreak monkey.
This is what the rhesus antigen is named after, because this is what they found, that we share red blood cell antigens with those things.
Wow.
All right, scary.
There you go.
So you get this rhesus antigen in your fetuses by 38 days gestation. What is that next to us?
Sorry, there's a car revving its engines like literally right next to us.
Oh man.
Oh well, you can still hear us. I know you can.
We know you can.
We know you can hear us.
you listen.
All right. Continue.
All right. So you're going to look for an Rh negative mother with an Rh positive fetus or an unknown fetus.
Yes.
Usually it's just going to be any Rh negative mother. You can get alloimmunization from as little as 0.1 milliliters of fetal blood.
0.1 milliliters.
That's
crazy.
That's a very small amount.
Not that much blood.
I mean, think about that mannequin we saw earlier, and like that is a tiny drop.
Well, and if you think about it, like in the first trimester, the fetus has about 2.5 mLs, like at maximum
total
in terms of blood. But even that's like way more than enough to cause the exposure of fetal blood to the.
So it's a tiny amount. You're going to get maternal anti-rhesus antigen IgG production, which then can cross the placenta and cause a hemolytic anemia in the fetus, which then results in hydrops fetalis.
Hydrops fetalis. Again, mentioned. Done.
Boom. This is really the money slide.
It's a little bit busy, but bear with us. Yeah. This is important.
So this is really what you need to know about Rh alloimmunization from our point of view. So you want to give your patients Rogam. If you have a mother who's less than 13 weeks, they have vaginal bleeding, first trimester, vaginal bleeding, and they're Rh negative, you give them 50 micrograms.
But can you give them a full dose of 300 micrograms?
Abso-freaking-lutely.
Abso-freaking-lutely.
Do you know what the risk of adverse effects is for Rogam?
No, I do not. What is it?
It's actually 11 in 2.9 million.
Oh, wow.
For those of you math nerds, it's 0.0004%.
That's quite the number needed to harm.
Yeah, it is. So just give Rogam. Just give it. It's fine. And, giving 300 has never been, instead of 50, has never been associated with any adverse effects. So don't worry about it. If you want to give 300, if you don't have any doubt as to what their gestational age is, just give 300. It's easy. If they're over 13 weeks and bleeding and Rh negative, give them 300. If they are postpartum and they have, so say like a urgent delivery just came in and the mom's Rh negative, and you delivered their baby in the ED, and OB's like, hey, I'm doing finishing up a C-section, be down in a second. Do him a favor. Give him some Rogam, 300 micrograms.
Absolutely.
In the next three cases. Oh, whoa, solid. Guys, I bet that guy's really cool. He's got a really loud car. Kind of like Cole.
So cool. Drag racing.
Drag racing, super cool. So there are a few cases where you're going to give Rogam even if you don't have vaginal bleeding. Those cases are an ectopic, which can happen with or without vaginal bleeding.
And I would definitely, in this case, 50 and 300, depending on the dates. In this case, though, just give the 300.
Just give them 300. For blunt abdominal trauma, they might know the dates, but any blunt abdominal trauma, you want to give them Rogam. You can probably just do the 300 here, too.
This is very much a board question.
Oh.
This is definitely on your boards. Know this.
I've missed this multiple times on Rush Review. And then interuterine field demise in the second or third trimester, you're going to want to give them 300 micrograms.
Yes.
And then, we're focusing on postpartum complications here, so kind of around the time of delivery. If they have a lot of vaginal bleeding, and they're kind of later on in pregnancy, you can consider giving more Rogam.
Yes. So it's kind of beyond the scope of this topic, but yes, if they are very far beyond 20 weeks, so 20 weeks is sort of the date when 300 should be enough. Beyond that, OBs might consider doing a Clauhari-Betke and potentially giving sequential doses of Rogam, up to 5 doses of 300 in 24 hours. But that'll be done in conjunction and consultation with OB. So just know that that's a possibility.
Yep. And just, if you have someone with a lot of vaginal bleeding who's later on in pregnancy, just consider you may need more Rogam, and don't be surprised if OB recommends that.
Indeed.
All right. So that's basically Rogam. Really, this slide is all you need for Rh alloimmunization.
Take a picture.
Doom. Let's go on to...
Who is that guy?
Oh.
Who is that handsome man with...
I don't know.
Smoking that pipe.
It's a dapper picture. I mean, look at that pipe.
Yeah, man.
I bet he used that pipe during deliveries as a famous obstetrician. And if anyone complained about it, he didn't care. Because it was God knows when. So this is...
Secondhand smoke from the day of birth. There you go.
Making quality humans since the 1700s.
Who is that?
So that's Dr. Sheehan.
Oh, Dr. Sheehan.
Dr. Sheehan. Oh, Dr. I think it's Henry Leing Sheehan or something like that. Yeah,
that's quite the name.
He's a fancy man. Look at that pipe.
Wow.
Anyway, so this is an uncommon complication of postpartum hemorrhage. It's actually more common in the developing world, but the incidence in the Western world, where modern medicine is prevalent, has been decreasing with good perinatal care and aggressive management of postpartum hemorrhage.
All right.
So let's move on. Let's talk about the pituitary, something you probably haven't thought about in a hot minute. You can see it here. It's kind of the lobular double globe structure in the brain. It produces most of your important hormones, ACTH, which ends up going to your adrenal glands and giving you cortisol, TSH, making thyroid hormone, prolactin, leading you to cause lactation, FSH, LH, GH, and then in the posterior pituitary, you've got ADH and oxytocin. So this is an important organ, and you can see a picture of it here. It's sitting in that sella, which, if you remember, that's where it lies in the brain. So what pituitary infarction or Sheehan syndrome, basically what happens is you have a large pituitary gland. I got an email. The increased size leads to increased metabolic demand and making it more susceptible to ischemia. Mm-hmm. And then when you have things like hypotension, you get end-organ damage. And one of the things that's susceptible in pregnancy is the pituitary. That's right. And so you get infarction of the pituitary from massive hemorrhage. It's much more common when you have massive hemorrhage with things like shock or hypotension or requiring a massive transfusion protocol. So you want to think about it more if the woman or your patient has a history of those. So let's talk about the diagnosis. There is the rapidity and severity of your symptoms really depend on a couple of factors, including how much of the pituitary actually infarcted, how rapid was the insult, and is it anterior or posterior? Now, the mean time to diagnosis...
How long is that? It's going to be pretty long.
It's pretty long. It's 20 years.
Holy crap. 20 years?
Eat your heart out, Matt Correa. I don't even think you can get one of these.
20 years.
Most of these people had pan-hypopituitarism at the diagnosis.
Wow.
But here's the deal. 53% of these patients only have mild symptoms.
Oh, okay.
So they're vague symptoms. And this leads to the delay in diagnosis.
Indeed.
Only 10% had severe symptoms, and these happen within days to weeks. These patients come in like, hey, I'm not lactating, I'm tired all the time, like more than tired, I'm not eating, and I'm losing a ton of weight. You can have moderate symptoms. You can just read through that there.
And arguably, the people that you really need to pick up are the ones that actually have severe symptoms.
Exactly. So for us, what we really care about are the people that have severe symptoms in the emergency department. Diabetes insipidus, so posterior pituitary infarction, is actually pretty rare in Sheehan's. It's usually going to affect your anterior pituitary, but it's something to think about. All right.
There you go.
So the EM version of pituitary infarction is pretty straightforward. So if you have active or recent severe postpartum hemorrhage and hypotension that's refractory to your appropriate resuscitation, then you should probably give them stress-dosed hydrocortisone. And it's an easy disposition because you're going to admit these patients.
Yes, indeed. And make sure when you have somebody that you suspect of, severe or moderate Sheehan syndrome, send off your endocrine labs. They might not come back immediately for you, but that's going to be very important for your inpatient obstetrician / medicine.
That's right.
Yeah.
Shoot off the cortisol. Send at least a TSH, a T3, T3 and T4. You can consider other labs in conjunction with your consultants, but definitely send off those guys.
You got it.
So,
and Mike, I think we've come to the end of our glorious talk
here.
Oh
man, what amazing!
Wow,
look at that!
Wow,
34 minutes of beauty. How many beers?
4 total.
At least
4 total.
Well, with that, we hope to see you guys on Tuesday. We're looking forward to a great discussion. And have a good morning, evening, or whatever time you're listening to this.
Goodbye.